Welcome to our educational video on the 2025 Guidelines for Acute Coronary Syndromes, developed by leading cardiovascular organizations. These guidelines are designed to enhance patient care with evidence-based strategies. Antiplatelet therapies are crucial in treating acute coronary syndromes. Dual therapy with aspirin and P2Y12 inhibitors like ticagrelor or prasugrel is recommended for 12 months, targeting platelet clumping to prevent blood clots. To mitigate bleeding risks, stomach protection medications are advised. Transitioning to a single medication like ticagrelor after the initial months can offer a safe alternative. Cholesterol management is paramount in these guidelines. High-intensity statin therapy is recommended for cholesterol reduction, with additional options like ezetimibe for further control of low-density lipoprotein cholesterol. Target levels below 70 mg per deciliter aim to reduce cardiovascular risk significantly. Invasive procedures for acute coronary syndromes have advanced, with percutaneous coronary intervention being a key intervention to unblock arteries. Accessing arteries through the radial approach in the wrist is preferred for its lower complication rates and quicker recovery. Complex cases may require additional interventions tailored to individual patient needs. These guidelines emphasize a comprehensive approach to acute coronary syndromes, focusing on optimal medication regimens, cholesterol management, and advanced procedures for improved patient outcomes. Stay tuned as we delve deeper into these essential updates for enhanced patient care.
Acute Coronary Syndromes Care. A report of the American College of Cardiology and American Heart Association Joint Committee on Clinical Practice Guidelines.
Hello and welcome. Today, we'll explore the 2025 Guidelines for Acute Coronary Syndromes. Discover the latest evidence-based strategies to enhance care and improve outcomes. Stay tuned, enjoy the highlights, and empower your clinical practice with this valuable and practical information for success.
Methods. A comprehensive literature search was conducted from July 2023 to April 2024. Clinical studies, systematic reviews and meta-analyses, and other evidence conducted on human participants were identified that were published in English from Medline, through PubMed, Embase, the Cochrane Library, Agency for Healthcare Research and Quality, and other selected databases relevant to this guideline. Structure. Many recommendations from previously published guidelines have been updated with new evidence, and new recommendations have been created when supported by published data. Evidence. Search of scientific acute coronary syndromes literature over past year. Recommendations revised per new evidence. Process. Professional Practice Committee. External peer review. Reviewed by the American Heart Association and American College of Cardiology Board of Directors. Standard of living. Funding. Funded out of the American Heart Association and American College of Cardiology general revenues. Does not use industry support. Table of Contents. Introduction. Overview of acute coronary syndromes. Initial evaluation and management of suspected acute coronary syndromes. Standard medical therapies for ST segment elevation myocardial infarction and non-ST segment elevation acute coronary syndromes. ST segment elevation myocardial infarction management. Reperfusion strategies. Non-ST segment elevation acute coronary syndromes. Routine invasive or selective invasive initial approach. Catheterization laboratory considerations in acute coronary syndromes. Management of cardiogenic shock. Complications of acute coronary syndromes. In-hospital issues in the management of acute coronary syndromes. Discharge, long-term management, and secondary prevention. Evidence gaps and future directions. Preamble. Since 1980, the American College of Cardiology and American Heart Association have translated scientific evidence into clinical practice guidelines with recommendations to improve cardiovascular health. These guidelines, which are based on systematic methods to evaluate and classify evidence, provide a foundation for the delivery of quality cardiovascular care. The American College of Cardiology and American Heart Association sponsor the development and publication of clinical practice guidelines without commercial support, and members volunteer their time to the writing and review efforts. Guidelines are official policy of the American College of Cardiology and American Heart Association. For some guidelines, the American College of Cardiology and American Heart Association collaborate with other organizations. Intended use. Clinical practice guidelines provide recommendations applicable to patients with or at risk of developing cardiovascular disease. The focus is on medical practice in the United States, but these guidelines are relevant to patients throughout the world. Although guidelines may be used to inform regulatory or payer decisions, the intent is to improve quality of care and align with patients' interests. Guidelines are intended to define practices meeting the needs of patients in most, but not all, circumstances and should not replace clinical judgment. Clinical implementation. Management, in accordance with guideline recommendations, is effective only when followed by both practitioners and patients. Adherence to recommendations can be enhanced by shared decision-making between clinicians and patients, with patient engagement in selecting interventions on the basis of individual values, preferences, and associated conditions and comorbidities. Methodology and modernization. The American College of Cardiology and American Heart Association Joint Committee on Clinical Practice Guidelines, Joint Committee, continuously reviews, updates, and modifies guideline methodology on the basis of published standards from organizations, including the National Academy of Medicine, formerly the Institute of Medicine, and on the basis of internal reevaluation. Similarly, presentation and delivery of guidelines are reevaluated and modified in response to evolving technologies and other factors to optimally facilitate dissemination of information to healthcare professionals at the point of care. Numerous modifications to the guidelines have been implemented to make them shorter and enhance user-friendliness. Guidelines are written and presented in a modular, knowledge chunk format in which each chunk includes a table of recommendations, a brief synopsis, recommendation-specific supportive text, and, when appropriate, flow diagrams or additional tables. Hyperlinked references are provided for each modular knowledge chunk to facilitate quick access and review. In recognition of the importance of cost, value considerations in certain guidelines, when appropriate and feasible, an assessment of value for a drug, device, or intervention may be performed in accordance with the American College of Cardiology and American Heart Association methodology. To ensure that guideline recommendations remain current, new data will be reviewed on an ongoing basis by the writing committee and staff. When applicable, recommendations will be updated with new evidence, or new recommendations will be created when supported by published evidence-based data. Going forward, targeted sections or knowledge chunks will be revised dynamically after publication and timely peer review of potentially practice-changing science. The previous designations of full revision and focused update have been phased out. For additional information and policies on guideline development, readers may consult the American College of Cardiology and American Heart Association Guideline Methodology Manual and other methodology articles. Selection of writing committee members. The Joint Committee strives to ensure that the Guideline Writing Committee contains requisite content expertise and is representative of the broader cardiovascular community by selection of experts across a spectrum of backgrounds, representing different geographic regions, sexes, races, ethnicities, intellectual perspectives or biases, and clinical practice settings. Organizations and professional societies with related interests and expertise are invited to participate as collaborators. Relationships with industry and other entities. The American College of Cardiology and American Heart Association have rigorous policies and methods to ensure that documents are developed without bias or improper influence. The complete policy on relationships with industry and other entities can be found at the following link below. Appendix 1 of the guideline lists writing committee members' comprehensive and relevant relationships with industry and other entities. For the purposes of full transparency, comprehensive and relevant disclosure information for the Joint Committee is also available at the following link below. Evidence Review and Evidence Review Committees. In developing recommendations, the Writing Committee uses evidence-based methodologies that are based on all available data. Literature searches focus on randomized controlled trials, but also include registries, non-randomized comparative and descriptive studies, case series, cohort studies, systematic reviews, and expert opinion. Only key references are cited. An independent evidence review committee is commissioned when there are greater than or equal to 1 questions deemed of utmost clinical importance and merit formal systematic review to determine which patients are most likely to benefit from a drug, device, or treatment strategy, and to what degree. Criteria for commissioning an evidence review committee and formal systematic review include absence of a current authoritative systematic review, feasibility of defining the benefit and risk in a time frame consistent with the writing of a guideline, relevance to a substantial number of patients, and likelihood that the findings can be translated into actionable recommendations. Evidence review committee members may include methodologists, epidemiologists, clinicians, and biostatisticians. Recommendations developed by the writing committee on the basis of the systematic review are marked SR. Guideline-directed medical therapy. The term guideline-directed medical therapy encompasses clinical evaluation, diagnostic testing, and both pharmacological and procedural treatments. For these and all recommended drug treatment regimens, the reader should confirm dosage with product insert material and evaluate for contraindications and interactions. Recommendations are limited to drugs, devices, and treatments approved for clinical use in the United States. Introduction, methodology, and evidence review. The recommendations listed in this guideline are, whenever possible, evidence-based. An initial extensive evidence review, which included literature derived from research involving human subjects, published in English and indexed in Medline through PubMed, Embase, the Cochrane Library, the Agency for Healthcare Research and Quality, and other selected databases relevant to this guideline, was conducted from July 2023 to April 2024. Key search words included but were not limited to the following: American College of Cardiology and American Heart Association Clinical Practice Guidelines, acute coronary syndrome, angina, unstable, anticoagulants, aspirin, atrial fibrillation, cardiovascular diseases, coronary artery disease, coronary syndrome, emergency medical services, fibrinolytic agents, hemorrhage, major adverse cardiovascular events, morphine, myocardial infarction, non-ST elevation myocardial infarction, percutaneous coronary intervention, pre-hospital, revascularization, risk, ST elevation myocardial infarction, time factors, treatment outcome. Additional relevant studies, which were published through April 2024 during the guideline writing process, were also considered by the writing committee and added to the evidence tables when appropriate. The final evidence tables summarize the evidence used by the writing committee to formulate recommendations. References selected and published in the present document are representative and not all-inclusive. Composition of the writing committee. The writing committee consisted of general cardiologists, interventional cardiologists, cardiovascular surgeons, critical care cardiologists, emergency physicians, cardiac imaging experts, advanced practice nurses, clinical pharmacists, and lay and patient representatives. The writing committee included representatives from the American Heart Association, American College of Cardiology, American College of Emergency Physicians, National Association of Emergency Medical Services Physicians, and Society for Cardiovascular Angiography and Interventions. Appendix 1 of the current document lists writing committee members' comprehensive and relevant relationships with industry and other entities. Guideline review and approval. The Joint Committee appointed a peer review committee to review the document. The peer review committee comprised individuals nominated by the American College of Cardiology, American Heart Association, and the collaborating organizations. Reviewers' relationships with industry and other entities information was distributed to the writing committee and is published in this document, Appendix 2. This document was approved for publication by the governing bodies of the American College of Cardiology and the American Heart Association and was endorsed by American College of Emergency Physicians, National Association of Emergency Medical Services Physicians, and Society for Cardiovascular Angiography and Interventions. Scope of the guideline. The scope of the 2025 American College of Cardiology, American Heart Association, American College of Emergency Physicians, National Association of Emergency Medical Services Physicians, Society for Cardiovascular Angiography and Interventions Guideline for the Management of Patients with Acute Coronary Syndromes, referred to hereafter as the 2025 Acute Coronary Syndromes Guideline, is to incorporate new evidence since the publication of the 2013 American College of Cardiology Foundation American Heart Association Guideline for the Management of ST Elevation Myocardial Infarction, the corresponding 2014 American Heart Association and American College of Cardiology Guideline for the Management of Patients with Non-ST Elevation Acute Coronary Syndromes, and the 2015 American College of Cardiology, American Heart Association, Society for Cardiovascular Angiography and Interventions focused update on primary percutaneous coronary intervention for patients with ST elevation myocardial infarction. The 2025 Acute Coronary Syndromes Guideline and the 2021 American College of Cardiology, American Heart Association, Society for Cardiovascular Angiography and Interventions Guideline for Coronary Artery Revascularization, Retire and Replace, respectively, the 2016 American College of Cardiology, American Heart Association Guideline focused update on duration of dual antiplatelet therapy in patients with coronary artery disease. This guideline primarily focuses on the management of type 1 acute myocardial infarction. It can be challenging to differentiate type 1 versus type 2 myocardial infarction in cases of uncertainty and depending on the benefits or risks of a specific diagnostic or therapeutic intervention. It may be appropriate to err on the side of considering an event a type 1 acute coronary syndrome event until established to be otherwise. In the United States, an estimated 805,000 acute myocardial infarctions occur annually, of which 605,000 are first myocardial infarction events and 200,000 are recurrent. Although significant morbidity and mortality are associated with myocardial infarction, 30-day and in-hospital mortality rates after ST segment elevation myocardial infarction have declined in part as a result of timely reperfusion and implementation of evidence-based secondary prevention. From 2011 to 2021 in the United States, the annual death rate attributable to coronary heart disease declined by 15%. The economic impact of myocardial infarction is also substantial, with the total annual cost estimated at $84.9 billion, including direct medical expenditures and indirect lost productivity and wages. The incidence of myocardial infarction is higher among Black males compared with non-Hispanic white males for reasons that are believed to be multifactorial. Potential factors that may contribute to this disparity include a higher prevalence of risk factors for coronary artery disease, less use of guideline-recommended medications post-myocardial infarction, and socioeconomic factors. In addition to racial disparities, there are sex-related disparities in the prevalence, presentation, treatment, and outcomes of acute coronary syndromes even after adjusting for confounding factors such as income, geography, and education. Women tend to present with acute coronary syndromes on average 10 years later than men and with a greater burden of developing cardiovascular disease risk factors. Although chest pain remains the most common symptom of acute myocardial infarction, women are more likely than men to present with accompanying non-chest pain symptoms. A delay in recognition of these symptoms can result in delays in presentation, diagnosis, and timely treatment of women with acute coronary syndromes. Studies have also shown that women presenting with acute coronary syndromes are less likely to be correctly diagnosed with an acute coronary syndromes, receive guideline-directed medical therapy, and or undergo coronary revascularization when indicated. Bridging these racial and sex gaps will require continued provider education, better understanding of barriers to accessing quality care and guideline-directed medical therapy, and changes at the community and legislative level to address social determinants of health such as income, employment status, neighborhood safety, and access to healthy foods. In developing the 2025 Acute Coronary Syndromes Guideline, the writing committee reviewed previously published guidelines and related scientific statements. Table 1 contains a list of these publications deemed pertinent to this writing effort. It is intended for use as a resource, obviating the need to repeat existing guideline recommendations. Some recommendations have been carried forward from previously published guidelines. If unchanged, those recommendations remain current. Any changes to the formatting or content of these recommendations are defined as modified. Formatting changes, exempli gratia, minor verbiage modifications such as pico, ts, structure, adapted, substantive changes, exempli gratia, major adaptations, such as a change in class of recommendation, level of evidence, drug, or device classification. Note: the PICO-TS framework is used to structure clinical and research questions in evidence-based medicine. PICO includes the elements population, intervention, comparison, and outcome, while TS expands the framework by adding time, the period during which outcomes are evaluated, and study type, the methodological design used, such as clinical trials, cohort studies, etc. This structure facilitates a more detailed and precise analysis of the issues raised. Changes are depicted in a footnote below the recommendation tables. Table 1. Associated Publications. Guidelines. Management of Blood Cholesterol. American Heart Association and American College of Cardiology, 2018. Management of Heart Failure. American Heart Association, American College of Cardiology, and the Heart Failure Society of America, 2022. Primary Prevention of Cardiovascular Disease. American College of Cardiology and American Heart Association, 2019. Others include stroke prevention, atrial fibrillation management, and more. Other relevant documents. Classification of cardiogenic shock. Society for Cardiovascular Angiography and Interventions, 2019. Invasive management of AMI with shock. American Heart Association, 2021. Cardiac Catheterization Guidelines. American Heart Association, 2024. Class of recommendation and level of evidence. The class of recommendation indicates the strength of recommendation, encompassing the estimated magnitude and certainty of benefit in proportion to risk. The level of evidence rates the quality of scientific evidence supporting the intervention on the basis of the type, quantity, and consistency of data from clinical trials and other sources. Table 2. Table 2. Applying the American College of Cardiology and American Heart Association class of recommendation and level of evidence to clinical strategies, interventions, treatments, or diagnostic testing in patient care, updated May 2019, is structured into two main sections. Class, strength of recommendation. 1. Class 1 strong. Benefit, risk. Actions are strongly recommended or indicated based on clear benefits. Examples of phrases: is recommended, is indicated or useful or effective, or should be performed. 2. Class 2A moderate. Benefit or risk. Actions are reasonable, with evidence supporting their usefulness. Phrases: is reasonable, can be effective or useful. 3. Class 2B weak. Benefit greater than or equal to risk. The usefulness or effectiveness is less established or uncertain. Phrases: may or might be considered. Usefulness is unclear. 4. Class 3. No benefit, moderate. Benefit equals risk. Not recommended as they provide no clear advantage. Phrases: is not recommended. 5. Class 3. Harm strong. Risk, benefit. These actions are potentially harmful and not advised. Phrases: causes harm, should not be performed. Level, quality of evidence. 1. Level A. Based on high-quality evidence from multiple randomized controlled trials, RCTs, or meta-analyses. 2. Level BR. Randomized. Moderate quality evidence from RCTs. 3. Level BNR. Non-randomized. Moderate quality evidence from well-designed non-randomized studies or observational data. 4. Level CLD. Limited data. Evidence includes studies with design limitations or limited population data. 5. Level CEO. Expert opinion. Recommendations based solely on expert clinical judgment. This table provides a comprehensive framework to guide clinicians on assessing the strength of recommendations and the quality of evidence for various clinical actions. The Section 1.6 titled Abbreviations. Section 1.6 provides a list of key abbreviations used throughout the document to ensure clarity and ease of reference for the readers. Familiarity with these terms is essential for understanding the guidelines and applying them effectively in clinical practice. Overview of acute coronary syndromes. Definition and classification of acute coronary syndromes. Acute coronary syndromes are typically caused by the disruption, rupture, or erosion of an unstable coronary artery atherosclerotic plaque with associated partial or complete coronary artery thrombosis and/or microemboli, resulting in diminished blood flow to the myocardium and subsequent myocardial ischemia, Figure 1. Acute coronary syndromes includes three related clinical conditions that exist along a continuum of severity. 1. Unstable angina. 2. Non-ST segment elevation myocardial infarction. And 3. ST elevation myocardial infarction. The initial diagnosis and classification of acute coronary syndromes should be based on the clinical history and symptomatology, interpretation of the electrocardiogram, Table 3, and assessment of cardiac troponin. Unstable angina is defined by transient myocardial ischemia leading to diminished flow in the absence of significant myonecrosis detected by circulating troponin. In contrast, patients with more prolonged or severe myocardial ischemia are diagnosed with MI and have elevated biomarkers of myonecrosis. Patients with non-ST elevation myocardial infarction may have a partially occluded coronary artery leading to subendocardial ischemia, while those with ST elevation myocardial infarction typically have a completely occluded vessel leading to transmural myocardial ischemia and infarction, Figure 2. The pathophysiology of acute coronary syndromes can be dynamic, and thus patients can rapidly progress from one clinical condition, exempli gratia, unstable angina, non-ST elevation myocardial infarction, ST elevation myocardial infarction, to another during the course of their presentation and initial evaluation and treatment. Other, less common causes of myocardial ischemia, among others, include coronary artery spasm, embolism, and dissection. This guideline will focus on the acute management of acute coronary syndromes, including unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction, which are presumed to result from atherosclerotic plaque rupture or plaque erosion and subsequent thrombosis. Under the universal definition of myocardial infarction, these myocardial infarction events would be classified as type 1 myocardial infarction events, Table 4. The diagnostic evaluation of chest pain and the management of type 2 myocardial infarction, spontaneous coronary artery dissection, and myocardial infarction with non-obstructive coronary artery disease are covered in separate documents. A detailed description of the approach to the evaluation of patients with chest pain can be found in the 2021 American Heart Association, American College of Cardiology, American Society of Echocardiography, American College of Chest Physicians, Society for Academic Emergency Medicine, Society of Cardiovascular Computed Tomography, Society for Cardiovascular Magnetic Resonance, Chest Pain Guideline. Progressive lipid accumulation and inflammation within an atherosclerotic plaque may lead to plaque instability. Rupture of the atherosclerotic plaque and exposure of plaque contents to the circulation may then culminate in activation of the coagulation cascade and subsequent thrombosis. The presence of thrombus may compromise flow to the myocardium, leading to myocardial ischemia and eventual myonecrosis. Since early initiation of therapy is imperative for patients with acute coronary syndromes, a high index of suspicion is warranted for those who present with signs and symptoms that could be consistent with myocardial ischemia. Patients with acute coronary syndromes are at the highest risk for cardiovascular complications acutely, including prior to hospital presentation and during the early hospital phase. With appropriate management, this risk begins to attenuate. However, patients remain at increased risk of recurrent cardiovascular events for several months to years after an acute coronary syndromes. This may in part be related to the acute inflammatory milieu that exists after acute coronary syndromes that may contribute to a heightened risk of recurrent events. Although the point at which a patient transitions from being a patient with an acute coronary syndromes to one with more stable or chronic coronary disease is incompletely defined. Many of the medications indicated at discharge in patients with an acute coronary syndromes are similar to those for the management of a patient with chronic coronary disease and should be extended more than a year beyond acute coronary syndromes. The long-term management of patients with acute coronary syndromes who are presumed to now have more stable coronary disease has been described in the 2023 American Heart Association, American College of Cardiology, American College of Clinical Pharmacy, American Society for Preventive Cardiology, National Lipid Association, and Preventive Cardiovascular Nurses Association Chronic Coronary Disease Guideline. Figure 1. Pathobiology of a type 1 myocardial infarction due to atherosclerotic plaque disruption. The pathobiology of a type 1 myocardial infarction due to atherosclerotic plaque disruption involves progressive lipid accumulation and inflammation within the plaque, leading to instability. When the plaque ruptures or erodes, its contents are exposed to the bloodstream, triggering the coagulation cascade and the formation of a thrombus. In the coronary arteries, this thrombus can obstruct blood flow to the myocardium, causing myocardial ischemia and ultimately leading to myonecrosis if left untreated. This process highlights the critical connection between plaque disruption, thrombosis, and heart muscle damage. Table 3. Electrocardiographic interpretation for patients with suspected acute coronary syndromes. This table provides guidance on the interpretation of electrocardiographic findings in patients suspected of having acute coronary syndromes, specifically distinguishing between non-ST elevation acute coronary syndromes and ST elevation myocardial infarction. Electrocardiographic evidence of ischemia. Non-ST elevation acute coronary syndromes. Dynamic horizontal or downsloping S-segment depression greater than or equal to 0.5 millimeters and greater than or equal to 2 contiguous leads. TWAVE inversion, 1 millimeters in greater than or equal to 2 contiguous leads with a prominent R wave or an RS ratio 1. Transient S-segment elevation may also be observed. ST elevation myocardial infarction. New or presumed new S-segment elevation of greater than or equal to 1 millimeters in greater than or equal to 2 contiguous leads, measured at the J point, for all leads except V2 to V3. For leads V2 to V3, greater than or equal to 2 millimeters in men greater than or equal to 40 years. Greater than or equal to 2.5 millimeters in men less than 40 years. Greater than or equal to 1.5 millimeters in women, regardless of age. Other observed electrocardiographic changes. Non-ST elevation acute coronary syndromes. Many patients exhibit nonspecific ST segment or TWAVE changes, or even a normal electrocardiogram. The absence of ischemic evidence on the electrocardiogram does not exclude acute coronary syndromes. ST elevation myocardial infarction. In cases of suspected left circumflex artery occlusion, obtain posterior leads, V7 to V9, especially with isolated S-segment depression greater than or equal to 0.5 millimeters in leads V1 to V3. This table emphasizes the importance of precise electrocardiogram interpretation in differentiating acute coronary syndromes types and guiding management strategies. References. In conclusion, this initial section of the 2025 Guideline for the Management of Patients with Acute Coronary Syndromes has laid a solid foundation, presenting updated evidence, methodologies, and collaborative insights to improve clinical practice and patient outcomes. This guideline stands as an essential resource for healthcare providers committed to optimizing care for patients with acute coronary syndromes. Thank you for joining us in this video on Medicina Interna. If you found this content helpful, we encourage you to subscribe to the channel and share your thoughts in the comments. Your feedback is invaluable as we continue to grow and enhance the quality of our videos. Stay tuned for the next sections, where we'll dive deeper into acute coronary syndromes management and treatment strategies. See you in the next video. Let's keep learning together. Until next time.